It is Monday morning. Your practice has 24 prior authorization requests sitting in the queue, every one keeping an infusion chair empty. This chart highlights the latest AMA data, showing the average physician and staff spend 13 hours every week processing 40 different prior authorizations, and nearly a third of those are denied, freezing treatment and sending cases into a tedious administrative loop. This workflow consumes an entire day and a half of staff time each week, pulling resources directly away from patient care and driving the severe burnout reported by 92% of radiation oncologists see treatment delays from authorization hurdles, cascading into emergency hospitalizations in 30% of cases and contributing to patient mortality in 7%. In oncology, a delayed approval is a measurable, adverse clinical outcome. Most general medical prior authorizations follow a predictable script, gathering documentation and matching it to payer criteria. But oncology requires a completely different approach. An oncology request demands branching alignment, specific CPT codes, pathology reports, biomarker thresholds, and exact NCCN guidelines. Yet perfectly documented cases hit a wall. Only 16% of physicians report the peer-to-peer health plan representative actually has the clinical qualifications to evaluate an oncology case. Submitting complex cancer treatments through generalized authorization workflows guarantees preventable denials and pulls oncologists away from patients to argue routine appeals. The regulatory landscape shifted in 2026 with the implementation of the CMS-0057 F mandate for impacted payers. This timeline graphic contrasts the strict new deadlines. Payers are now legally bound to deliver standard decisions within 7 days and expedited requests within 72 hours. Crucially, they must provide a specific, documented reason for every denial. Practices no longer have to argue against vague rejections. When a payer provides a stated reason, your team can counter directly with precise NCCN citations, provided you have the infrastructure to respond quickly. To handle this specific complexity, practices are replacing generalist in-house staff with outsourced teams of AAPC-credentialed oncology experts driven by clinical AI. The process starts with an AI reasoning engine reading the pathology reports. It extracts biomarker results and matches the clinical picture directly to NCCN Category 1 evidence before a human ever opens the file. Looking at this breakdown, the AI executes 80% of the workflow, handling document classification and eligibility checks. This reserves the credentialed human specialists exclusively for the 20% that requires deep clinical judgment and peer-to-peer preparation. Pairing automated processing speed with highly specialized human strategy effectively eliminates the structural friction of oncology authorizations. This chart compares the financial burden. Hiring an in-house coordinator costs up to $84,000 a year fully loaded, compared to a $399 weekly rate for an outsourced team. This model delivers a 4-hour standard turnaround time and an 81.7% success rate overturning appeal denials. The outsourced team works directly inside your existing EMR via secure access, eliminating data re-entry, with a go-live timeline of just 5 to 10 days for a pilot. Deploying an AI-powered specialty team stops revenue leakage, gets staff off the phone, and ensures cancer patients start their treatment exactly when they need it.